A 44-year-old woman with intractable pain due to metastatic lung cancer.
Lung cancer is the leading cause of cancer deaths in Malaysia for both men and women. Your lungs are two spongy organs in your chest. The left lung is divided into two lobes, or sections, and the right lung has 3 lobes. When you breathe in, air enters your nose or mouth and passes into your trachea, or windpipe. At the carina, the trachea divides into 2 bronchi, then branches into smaller bronchioles. The bronchioles end in tiny air sacs, or alveoli. Here, the oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale. Your lungs are encased by pleura, a thin membrane that protects them and helps them slide back and forth as you breathe in and out. Underneath your lungs is the diaphragm, a smooth, thin muscle that helps your lungs expand and contract as you breathe. Your lungs are connected to small collections of immune system cells called lymph nodes by way of lymphatic vessels. You have groups of these lymph nodes near your lungs, above your collarbones, and behind your breastbone, as well as in other parts of your body. Lung cancers most commonly start in the bronchi, but they can also begin in the trachea, bronchioles, or alveoli. Early lung cancer typically does not cause symptoms. As the cancer grows, you may experience symptoms such as a cough that gets worse or does not go away, shortness of breath, chest pain, and wheezing. Other symptoms of lung cancer include coughing up blood, hoarseness, weight loss without trying, and frequent lung infections, such as pneumonia. Other health problems may cause these symptoms. You should see your doctor if you have any symptoms you're concerned about. The staging of lung cancer refers to the extent of the disease. If you have the most common form of lung cancer, or non-small cell lung cancer, it will be staged according to the size of the tumor and whether it has spread to the lymph nodes or other organs of the body. In the occult, or hidden stage, cancer cells are found in coughed-up mucus or in other lung fluids, but no tumor can be seen in the lungs. Stage 0 is not considered invasive because the cancer cells are found in the innermost lining of the air passages but have not grown through it. Stage 1A is considered invasive cancer because the tumor has grown through the inner lining of the airways into the deep lung tissue and has not spread to distant sites. In Stage 1B, the tumor has spread to a main bronchus or has grown through the lung into the inner layer of the pleura. In Stage 2A, the tumor has spread to nearby lymph nodes on the same side of the chest as the tumor. There are 2 scenarios that can occur with Stage 2B lung cancer. 1, where cancer cells have not spread to nearby lymph nodes, but have invaded the chest wall, diaphragm, pleura, the membranes surrounding the heart, or a main bronchus. In the second scenario for Stage 2B, the cancer has spread to the lymph nodes on the same side of the chest as the tumor, or has grown into a main bronchus, or has grown through the lung into the pleura. In Stage 3A, the cancer cells have spread to the lymph nodes on the same side as the lung tumor. Also, the cancer may have spread to the chest wall, diaphragm, pleura, the membranes around the heart, or a main bronchus, but not the trachea. In Stage 3B, the tumor has spread to lymph nodes above the collarbone or on the other side of the chest. The cancer may have spread to nearby structures or to more than one place in the same lung. In Stage 4, cancer has spread to other parts of the body, such as the brain, liver, kidneys, adrenal glands, or bone. If you have small cell lung cancer, it is often staged using a simpler two-part system because treatment options don't vary much between the more detailed stages used to describe non-small cell lung cancer. In limited stage small cell lung cancer, cancer cells are found in one lung and may be found in the tissues between the lungs and in nearby lymph nodes. If cancer is found in the other lung, in the lymph nodes on the other side of the chest, or in other parts of the body, it is called extensive stage. Treatment options for cancer include local therapies, such as surgery and radiation therapy, and systemic therapies, such as chemotherapy and targeted therapy. You may receive one or a combination of these treatments. There are several surgical options, depending on the type and stage of the cancer. During a wedge resection, or segmenectomy, the tumor and a small margin of healthy tissue are removed. In a lobectomy, or sleeve lobectomy, one lobe of a lung is removed. During a pneumonectomy, the surgeon removes the entire lung. In a sleeve resection, a diseased section of a large airway is removed, and the healthy ends are reattached. During any of these procedures, your surgeon may remove lymph to check them for signs of cancer. Radiation therapy, or radiotherapy, is a local treatment that uses high-energy rays to kill or shrink cancer cells to relieve symptoms. External beam radiation therapy, or ERBT, is directed at the cancer's location from a machine outside your body. Brachytherapy, or internal radiation therapy, often in the form of pellets, is most commonly used to help relieve blockage of the large airways by cancer. Chemotherapy is a systemic treatment that uses drugs to stop the growth of the cancer cells by either killing them or inhibiting their cell division. Once the drugs enter the bloodstream, they can travel and reach cancer cells throughout the body. Targeted therapies are newer cancer treatments that work by focusing on specific genetic abnormalities of cancer cells. One targeted therapy, bevacizumab, starves the tumor by stopping it from creating a new blood supply. Another targeted therapy, erlotinib, stops tumor growth by blocking the chemicals that signal the cancer cells to grow and divide. Lung cancer prevention includes actions you can take to lower your chance of developing cancer. The most important thing you can do to prevent lung cancer is to not start smoking, or to quit smoking if you do. Avoid breathing in other people's smoke. Test your home for radon, a known carcinogen or cancer-causing agent. Avoid exposure to cancer-causing chemicals at work. Maintain a healthy weight because being overweight can cause the body to circulate higher levels of certain hormones that can stimulate cancer growth. Eat a diet full of fruits and vegetables, which are packed with substances that can help reduce your risk of cancer and help control your weight. Exercise regularly, which will help you control your weight and reduce your risk through its positive influence on your hormone levels and immune system. Be sure and talk to your doctor about ways to reduce your risk of lung cancer.
Definition: metastatic cancer is a cancer that has spread from the part of the body where it started to other parts of the body. Lung cancer can spread to almost any organ of the body, but most often it will spread to adrenal glands, liver, bones, or brain. It can also spread to the other lung.
Over time, we can see the ability of lung cancer to spread. So some of those cells have the ability to get into blood vessels or something that we call lymphatic channels that drain to different glands throughout the body. And that's how lung cancer can spread. The most common sites of spread are brain to the bone and liver. Sometimes people will often have cancer outside the lung, so in the lining of the lung, something called the pleura, and lung cancer can even go to the other lung.
The cancer that arises originally from the lung will be considered lung cancer. But then if the cancer arises from some other part of the organ and eventually metastasized or migrated to the lung, they will not be considered to be lung cancer. They will be called lung metastasis from other organs such as colon or breast cancer.
Applications in medicine. The World Health Organization ladder for cancer-related pain is a well-validated and generally effective approach to pain management that recommends non-opioid therapy for mild pain and opioid therapy for moderate or severe pain. For patients with cancer-related pain that is refractory to opioids, treatment options include opioid rotation, optimization of non-opioid analgesics, and interventional therapies.
Some of the new options that are available for lung cancer treatment are stereotactic body radiotherapy. This is a very specific type of radiation therapy that can really pinpoint the tumor and not injure other good lung. Many of our patients with lung cancer have other lung diseases like emphysema or chronic bronchitis, and to give radiation therapy to some areas of the lung that are not appropriate may cause injury that might be irreversible and can compromise their lung function. By being able to pinpoint that radiation, we can localize the effects of radiation to the tumor itself. So these new forms of radiation therapy are very, very valuable. In addition to that, there are new drugs that can attack some of the molecular mutations that occur on some lung cancers. These are very specific drugs, and it's very important to diagnose those mutations that occur on these cancers so that patients can be afforded all the possible therapies that are available. We frequently will use brachytherapy to treat patients who have tumors that have blocked their airways. These treatments are very effective at reducing coughing of blood, opening up the airways so that it improves shortness of breath. It can help treat pneumonias that are trapped behind the tumors in the lung, and can be very, very helpful in reducing cough. So all of these are very, very important in patients who have lung cancer.
PRAS, ketorolac, glucocorticoids, hydrocodone, and intractable analgesics agents can be used as pain relievers. Palliative sedation is an intervention to relieve intractable pain in terminally ill patients by means of continuous infusion of a sedation in medication. The discomfort of most dying patients can be controlled with state-of-the-art palliative care.
Good afternoon, everybody. We might make a start. I'm Peter Hudson on behalf of the Centre for Palliative Care. Welcome to this afternoon's forum. I'd like to formally acknowledge the traditional owners of this land, the Wurundjeri Nation, and pay respect to their elders and families. So it's now my great pleasure to introduce our main presenter, and it's Associate Professor Jennifer Phillip. Jenny is the Deputy Director of Palliative Medicine here at St Vincent's Hospital and is Co-Deputy Director of the Centre for Palliative Care, which is a collaborative centre of the University of Melbourne. Jenny is a palliative care physician with extensive experience predominantly in hospital consultancy setting, and Jenny's research agenda has largely focused on developing models of palliative care in COPD, glioma, aged care, and also in end-of-life care issues in the emergency department. Jenny is a very close colleague of mine and admired by many in the field for her wisdom, so please make her feel welcome.
Thanks, Peter. And as Peter said, it's tremendous that people have come today. Thank you. I hope it will be an interesting discussion. I am going to take you on a bit of a cook's tour through some of the literature around sedation, both around the incidence, how we might define it or think about it, in particular sort of standardising some of the terms that we use. Show you and present in a little bit of detail some guidelines that have been published, and I'm just focusing on one particular set of guidelines, although there are a number, some outcomes of what's been done, and then I really want to spend the second half of the session having a discussion with a panel around some cases that I think explores some of the practical issues that we really encounter at the bedside when we're caring for people at the end of life. So I guess the first half is sort of conceptual and showing you and reminding us all what's in the literature, and the second half is the nitty-gritty sort of what you do or what might one do, and there's obviously potentially more than one way. In 1994, Vittorio Ventafrida from Italy published a study of home care patients in his home country, and citing that 53% of these patients had sedation at the end of life. And I'm old enough to remember that. And it actually created a bit of a fuss. People were sort of quite surprised that this figure was as high as that. And I'm just wondering, whilst sort of in the interests of straw polls, what people, if they would reflect on their own practice of what might be the incidence of sedation in their own practice. And perhaps, you know, thinking about that, would you maybe put your hand up if you think it's maybe less than 10%? Anyone? Not many? Maybe 20 to 50%? Yeah, quite a few. More than 50%? Yeah, quite a few. Yeah, so there's a big spread. And I think that and that's a big spread in the literature too, as you can see, 15 to 67% is cited. And I think this relates to a number of things, partly possibly because we're talking about different things. What might be sort of considered sedation at the end of life to some might not be thought to be that. There's different approaches in the level, in the timing or the temporal nature of it, in the indications and methods. So the differing terms, all of these have been used, including total pharmacological sedation, which sort of gets a bit uncomfortable perhaps. And I guess for the purposes of this talk, I'm going to use the term palliative sedation. There is different approaches, as said, about what is sedation. So in some of the studies, when people are reviewing the literature and citing this, they exclude mild sedation. They're included in others. And some of them don't really define what is going on at the bedside. They're just saying there's sedation. Levels of sedation might differ from perhaps mild or conscious sedation, which is when someone might be just a little bit sleepy or just a bit of anxiolytic, versus right through to perhaps deep sedation. As I said, the temporal nature might differ, so it might be intermittent. Some people use the term temporary, respite, night sedation, versus a continuous sedation. The medications used differ, and the target symptoms for which this might be done in the first instance or in the second instance appears to differ substantially. So Marita in 2002 undertook a systematic review of all the studies that they could determine which used sedative medications or which included an intention to reduce consciousness. And they, in an attempt to try to standardise some of the language around this, they came up with this notion that sedation includes two core factors. Firstly, the presence of severe suffering refractory to standard palliative management, and secondly, the use of sedative medications with the primary aim to relieve distress. And then they came up with a sort of a slightly complex table, and you can see on the left is, first of all, the degree of sedation, which might be mild, whereby consciousness is maintained, or deep, whereby perhaps complete unconsciousness is achieved. The duration, again, intermittent or continuous. So intermittent is when there might be sometimes when the patient is still alert, and then other times when they're not. The pharmacological properties of the medication. So primary sedation, when the sedative medications are used for their sedative effect. They don't actually have an effect on the underlying symptoms. So they're not a pain medication which in turn makes them sedated. It's actually a sedating medication versus a secondary one, which is obviously the latter. The symptoms, they suggested that if we're using this for symptoms, we need to describe these according to standard diagnostic criteria. And the target populations also should be described using validated tools, so performance status tools. So we're all comparing the same group of patients. Prognostic tools, we can get a sense of where the patient is in their illness. Classens tried to classify this a little further, and this looks complicated, but actually I think as a clinician it makes intuitive sense. So this is really a matrix of some of those levels of sedation and also the temporal nature and then the reasons for doing it, or the acute or non-acute reasons for doing it. So mild intermittent sedation is intermittent, mild reduction of consciousness, but the person's still reactive, probably still talking to you a little, versus mild continuous, where the same sort of cognitive state but continuing on. Deep intermittent and non-acute. So starting to get complex, I know, but so there's intermittent reduction of consciousness for a non-acute refractory symptom. So perhaps a refractory dyspnea that you are looking to induce short periods of reduced consciousness. And then during those times the patient is deeply sedated. Deep intermittent acute. So this might be when a person has an acute event and you need to respond acutely and you need to help that patient. The way of responding is going to be for that patient to be asleep or unconscious. And then deep continuous non-acute, and that might be what some of us think about when we're talking about palliative sedation, that sort of ongoing sedation, usually until the end of life. Deep continuous acute, so in the setting of a catastrophic event, a hemorrhage, for example, where you need to respond and the patient needs to probably reach a level of unconsciousness to be comfortable until they die. So it does get sort of complex. So I think using all of that sort of terminology and by way of background, Nathan Cherney, on behalf of the European Association for Palliative Care, came up with a definition, which is that palliative sedation is the monitored use of medications intended to induce a state of decreased or absent awareness in order to relieve the burden of otherwise intractable suffering in a manner that's ethically acceptable to the patient, family and healthcare providers. So unpacking this, intractable suffering is intolerable, so it's determined on the basis of the patient evaluation or, if they're unable, on their proxy in collaboration with staff and families. It's refractory, so all the sensible treatments that we have available have been tried and unhelpful based on skilled assessment, team consensus, and there doesn't seem to be another available treatment to reverse this, either within the time frame or within sort of a reasonable risk-benefit ratio for the patient. And the goal is to relieve the burden of suffering. So, following this, the European Association, along with some others, but I'm really, I guess, presenting the European guidelines, came up with guidelines. And you might say, well, why do we need guidelines? Well, I think that the guidelines are potentially, or are useful because of the potential adverse outcomes and risks of sedation. First of all, the obvious risk of impairment, loss of ability, family distress. Paradoxically, as you know, some people can get agitated. And this risk of hastened death, which I'll come back to. And we need guidelines because there are problem practices, and I'm sure we all know that. There are clinicians who abuse this approach, and in fact their intention is to hasten death, either through excessive dose or use of sedation in the presence of no symptoms. There's injudicious use of palliative sedation, or indeed of withholding palliative sedation. And indeed there's substandard clinical practice around describing some of the populations, what might be the indications. Has this patient really been through the best treatment that we can provide? So I want to walk you through the EAPC framework for procedural guidelines. It's a little dry, so bear with me, but I hope that highlighting some of these things that might come up in the discussion later. So firstly, these guidelines recommend preemptive discussion of the role of sedation in end-of-life care and contingency planning. And I must say this is not something that I routinely do, but it'd be interesting if people in the audience actually do this or practice this differently. Secondly, they recommend describing the indications in that service whereby sedation might be considered. And they suggest if distress is intolerable due to physical symptoms or refractory symptoms, they suggest using continuous deep sedation only in the terminal stages. Transient or respite sedation might be indicated earlier in the illness trajectory, and only occasionally do the guidelines suggest using sedation for severe non-physical symptoms. And I'll talk about this a little bit more. They talk about special precautions around the non-physical refractory symptoms. And they say these are different because they're harder to establish that they are truly refractory. Because such symptoms, anxiety, depression, fear, are dynamic and changeable, and indeed adaptation is common. That the standard treatment of these symptoms has a low intrinsic morbidity, and that they're not necessarily indicative of advanced disease, unlike, for example, dyspnea, which often is. And therefore, in the presence of these non-physical refractory symptoms, the guidelines suggest that they should only be used for patients with sedation should only be used for patients with advanced disease, that it should be declared refractory only with repeated and skilled psychological specialist assessment in a context of a relationship that's been formed and following trials of routine therapy, that there should be multidisciplinary approach in considering this, that if it's appropriate, then it should be used initially at least on a respite basis or a intermittent basis, and only continuously used if repeated respite trials have been performed and are not achieving sort of adequate relief. The guidelines suggest describing the evaluation and consultation procedures that should occur in the setting of sedation. So evaluating the disease, potential treatable causes, the prognosis, having multiple professional palliative care input into it. They talk about specific consent requirements if the situation is non-critical. So this is a patient who, for example, you have time to talk through these issues. They say that we should, in these consent discussions, talk about the general condition, what treatments have been tried, the rationale and the aims of sedation, how it will be administered, what the anticipated effects and risks of that are, what care will be given during sedation, and also what the outcomes will be if the sedation doesn't occur. The consent should involve an ongoing commitment to provide care and to the patient well-being, and should involve discussion with the family if present. So it all sounds very sort of a bit overwhelming and almost a little bit bureaucratic, but they do make the point that in the case of terminally ill patients who have no advance directive, no healthcare proxy, and who are in severe distress while actively dying, then provisions of comfort measures is the standard of care and should be the default strategy for clinical treatment decisions. So I think that in the setting of severe distress, when you need to react quickly, then the comfort of the patient is the standard of care, or provision of sedation is appropriate and may be instituted as the standard of care, not necessarily with all these consent procedures. So the guidelines indicate the need to discuss the decision-making with the patient's family. They talk about the selection of sedation method, in general suggesting the lowest dose necessary to relieve the suffering, unless it's an emergency. Potentially you may down titrate. You may suggest going to continuous deep sedation first if the suffering is intense and refractory, if death is imminent, if the patient's wishes is explicit, or if it's an end-of-life catastrophic event. The guidelines detail dose titration and patient monitoring and care, and talk about the sort of balance between suffering, level of consciousness and adverse effects. That doses may be increased or decreased according to the suppression of conscious levels and also according to adverse effects. But if you're doing that, to document why, what the reasons are, what the response is. I think the issue of monitoring is an interesting one. If it's a short-term intermittent sedation situation, then potentially monitoring of vital signs may be appropriate and indicated. If the goal is comfort, and particularly if it's end of life, then monitoring is of their comfort and the sedation should be adjusted accordingly. Getting close to the end of these guidelines, they suggest that there should be specific guidance around decisions of hydration and nutrition in usual medications, but the decisions around artificial hydration and nutrition is independent of the decision regarding sedation. And those medications directed towards the palliative management of symptoms should continue. Attention should be given to the care and information needs of the family, and attention should also be given to the care of the healthcare professionals involved. So those are the guidelines. What do we do in practice? In a study by Claessens published in 2011, a prospective study of 266 patients in Belgium as they were admitted to a palliative care unit, they found that 7.5% of these were administered palliative sedation according to those definitions and language and guidelines that we talked about. This was started a mean 2.5 days before death. The patients had a palliative prognostic score of 40, had a good Glasgow Coma Scale. They were bed-bound, but they did have extensive disease, but reasonably normal conscious state. They had an average of 5 symptoms, the most prevalent being listed there: pain, fatigue, depression, drowsiness, loss of well-being. 40% started as mild continuous sedation, 40% as deep sedation. Of note, 45% changed, and almost all of these went from mild to deep, indicating some titration against the symptom. And of those who didn't change sedation form, it started a median of 2 days before death, and in most cases it was a deep sedation situation. All patients gave consent. So the authors concluded that palliative sedation was exceptional, and when suffering was refractory, it was for patients, reserved for patients near the end of life, and that it was a consensual process. Maltoni in 2012 published a study in the Journal of Clinical Oncology, which was a systematic review of studies that the studies were of patients who had undergone palliative sedation, and the authors were particularly interested in the survival of these patients. They identified 10 retrospective studies, or prospective non-randomised studies, which included 34% of the total cohort of 1,800 consecutive patients were sedated, and you can see the range there from 15 to 67%. The reasons for sedation were fairly similar: delirium, most commonly, dyspnea and pain. The mean duration of sedation was from less than a day to about 12.5 days. Midazolam was the most commonly used drug in 9 of 10 studies. Psychotropics were also quite frequently used, but usually in conjunction with benzodiazepines. Proportional sedation was most common, whereby the sedation was titrated against the response, and few patients were given deep sedation at the very beginning. Survival from time of admission to the palliative care unit for those who were sedated ranged from 7 to 36.5 days, for those who were non-sedated from 4 to 39.5 days, and there was no significant difference between the two groups. And the authors concluded, within the parameters and the limitations of their studies, that actually sedation was not associated with reduction of survival. So in summary, palliative sedation involves refractory symptoms, where the goal is relief of symptoms. We have guidelines that are fairly explicit, and we should be thinking about or mindful of those guidelines when we're instituting sedation. But I guess really it boils down to really detailed attention to assessment, relief and level of sedation, as well as, I think, deep reflection on the intention in this situation. It should be proportional according to the response. So sedation, if you're achieving relief of the symptom, then the authors of the guidelines would suggest there's no requirement to escalate the sedation at that level. As best we can, it should be consensual with the patient, family, and I would also suggest the team in there. And it requires careful attention to family and staff as caregivers. I think there are some issues that the literature throws up for me that I believe require further consideration. And the first is how we decide or define what is refractory. And I suggest that often it's really a definition that's in the domain of the physician or the healthcare team. And I'm wondering what role the patient in that. How do we decide that this symptom is one whereby sedation is an appropriate response, whereby we don't, go down that route or that route. I think it's very interesting to consider in more detail this notion of refractory physical symptoms versus refractory psychological symptoms. We regard them differently, and yet we know that they are intrinsically linked, that dyspnea and anxiety are frequently linked and feed off each other, and yet we're talking about them as being sort of separate paradigms. I think the issues around consent are particularly interesting and probably throw up a number of challenges for me in my practice. I think the issues around the role of the family and what role the family to either request or deny sedation in the attempt when you're looking after a patient who's at the end of life. I believe that the issue of raising this as an option with patients relatively early in their illness course raises interesting challenges, and there might be some thoughts or comment around this. How do we enable consent and enable this as an option, yet at the same time, is that reassuring or indeed frightening for people? And artificial hydration and nutrition is probably something that is worthy of further discussion, particularly if sedation is being used earlier in an illness trajectory.
CANS, opioid-induced hyperalgesia, is a phenomenon whereby exposure to opioids sensitizes a patient to a pain stimulus, causing a paradoxical increase in pains as seen in this patient.
I guess complicated from an assessment point of view, but also from the ethical discussions. And I think that probably for the rest of eternity, we're going to be discussing the ethical difficulties that surround palliative sedation. Simply put, we're hoping to alleviate those people who have alleviate the suffering of those people who have refractory symptoms by using palliative sedation. And the common symptoms that people are comfortable with using sedation would be things like agitated delirium, severe dyspnea, and perhaps less commonly pain and other symptoms. Palliative sedation gets complicated when you start to talk about should you use that for existential distress or psychological suffering, because of the difficulty of deciding when that may truly be refractory, how much support you have to have from the interdisciplinary team and trying to help someone with psychological distress or existential suffering before you decide that that is truly a refractory problem. And when you look at the guidelines developed by the European Association of Palliative Care and certainly some groups in Canada and national organizations in the United States, that is the one that is often the most difficult to deal with. And you see people opt for different approaches, which is one is to park it and say, we've chosen not to deal with it. And other people are braver and take a stand. And it probably doesn't matter which approach you take, it's almost guaranteed to generate editorials or follow-up articles with people weighing in on that particular issue. Well, I guess the ethical issue is around intent. I suppose simply put, if your intent is to make the patient more comfortable because they have a refractory problem, there's nothing else you can do about the agitated delirium short of helping the person to sleep, or the refractory dyspnea that makes the person feel like they're choking to death other than put them to sleep, then the intent to make that person comfortable by using a sedating medication, I'm very comfortable with that. It's not my intent for that patient to die any sooner. Is it possible that as a consequence of using sedation, it may happen? It may, although the evidence suggests that people live probably about the same whether you use palliative sedation or not. But those are very difficult studies to do in a way that truly help to answer absolutely every question. So that is that's probably the fundamental ethical thing, is the issue of intent. Essentially, if you walk into someone's room with a syringe of potassium chloride and inject it intravenously, your intent was for the patient to die. As a secondary consequence, I suppose you might alleviate their suffering if that's your intent. But certainly for most ethicists, when I've read this discussion, that's what it centers around. Your intent is to relieve suffering, not to cause death. It does get more complicated than that, because you can obviously start to you can move that on and say, well, I believe in euthanasia, and my intent in injecting the person with potassium chloride is to make them more comfortable. Yes, I know as a secondary consequence, like they're going to die. So you can twist that argument around. You know, that's just the ethical component. Obviously, from a religious, spiritual worldview, there's other perspectives that come into it. Life is sacrosanct, and that becomes a very again, the discussion just gets more and more complicated, and that's why I say I think we're going to be discussing this forever. If someone has agitated delirium and that's refractory, by definition, that patient cannot participate in that discussion. Otherwise, they don't have an agitated delirium. The family certainly can. And I think where we have these discussions with families and the problem is truly severe, most people are comfortable with it. But you find different nuances, which is where the agitated delirium may be distressing for the nursing staff, but the family still finds some benefit in that interaction. And under those circumstances, families may want more time before they would agree to a palliative sedation approach, and may never agree to it. Perhaps with support and best nursing care, they would be okay without ever using palliative sedation. So we need to be careful not to push our belief that palliative sedation has to go ahead on families in that setting. In the case of refractory dyspnea, by definition, the patient is involved in the care, because it's their description of the shortness of breath as being intolerable with no relief from the interventions that you've put in place. So then the patient certainly is centrally involved in that discussion. And you should obviously involve the families as well, and hopefully they will agree. And there's always, most of these situations with good communication, as in most things in healthcare, discussions around palliative sedation go very well. But the human condition is complicated, and families are complicated, and there will always be difficulties at the bedside with some of those discussions.
Conclusion. The decision to pursue palliative sedation in this case was the culmination of many multidisciplinary conversations with the patient and her family. After making the difficult decision to pursue palliative sedation, the patient expressed great sadness but also a sense of relief that her suffering could be alleviated.